So, welcoming Professor Kaushik, and she'll be talking to us about medical management in glaucoma. A brief overview.
Hello, good afternoon. And I know you're all waiting for lunch. And frankly, this is not one of the most exciting things to keep you all awake, but it's important. So I think I'll just try to give a brief overview of what is it that we do in glaucoma. Of course, you know it's a chronic optic neuropathy with the corresponding visual field defects, right? The IOP is neither essential nor required for a diagnosis. Please remember that. So glaucoma is defined by the disc and the field, and the intraocular pressure is just incidental in this whole story. And yet it's important because you need to reduce the IOP because it's the only thing you can do. There's nothing else that you can do to arrest that optic neuropathy, as many clinical trials have proven, except reduce the IOP. What do we have at our disposal? How do we start and how do we continue? So that'll be the brief thing. So remember, the fundamental goal of treatment is this. This is a person with glaucoma. Is this working? Yeah. So this is the glaucomatous rate of RGC loss. And this blue thing is normal. And the idea is that if you treat it, you try to bring the rate of RGC loss almost equal to normal, though it never is. And as you can see, the earlier you treat it, the more chance it is that this patient is going to have useful vision in his lifetime. So the risk factors, of course, we know: elevated IOP, family history, race, genetic factors, of which the only thing that you as a doctor and as an ophthalmologist can do is control the IOP. And remember, lowering the IOP is important in all forms. So OHT, normal tension, POAG, any glaucoma that you have, all studies have shown that lowering the IOP is beneficial rather than not. The next question is setting a goal. As Paul Chandler said it best, if you have early primary open-angle glaucoma with early field defects, less than 18 or a 25% reduction, moderate, you would require about 30%, but keep it at mid-teens, and advanced with a ratio of more than 0.8, you need it in the low teens or about 12 or at least 50% reduction. So this is the mool mantra of setting a goal when you have a patient. So obviously there is no such formula across which you can say this is what I'm going to do. The target pressure, as you can see, therefore needs to be individualized to the patient sitting in front of you. The main thing that is dependent on is the initial pressure, the stage of disease, the life expectancy, the rate of damage is important, and corneal thickness. And then you need to maintain the functional status of the patient better. The modalities, of course, are eye drops. So that's what this talk is about: laser and surgery. So we'll talk about eye drops. What do we start with? We always start with PG analogs because there's science. There's no such thing as, in a country like India, we will start with timolol. No. Whether or not you're in India or in Timbuktu or in the US, the science is that prostaglandin analogs are the first line in primary open-angle glaucoma because less drops, less side effects, but of course there is the caveat of cost. So the treatment decisions, you need to see that at least 20% is reduced. So if you have a patient who is 26, and then you start a medication and the next time he's 24, then you add another one. That makes no sense at all. All my residents are thrown out of the room and they get hell if they do not tell me the patient is on Dimox, Comic and blah blah. Dimox se pehle kya tha? And then they look at me as if I am a little crazy. How do I know Dimox se pehle? No. Somebody has written Dimox. At the time of writing Dimox, there has to be a parchi. 9 out of 10 times, if I ask the patient, parchi dikhao doctor ki, some little paper will come out where there might be an NCT of 40. It doesn't matter. But there has been something there, and you need to know whether or not your medication is working. And why do we like monotherapy? Because there's better compliance. That's obvious. The lesser drops you need to put in a day, the more likely you're going to be compliant. And the washout is eliminated. So if you put one and then you put the other 5 minutes later and then you put a third 10 minutes later, you're likely to wash out medication. So the washout is eliminated. So compliance and washout. Of course, it's better. There was a study which showed that if you have 2 meds, the compliance was 24%. If you have 3 meds, it's only 5.6%. But if you went up to 4 meds, the compliance dropped to just 0.2%. Imagine, just 2 out of 1,000 patients of glaucoma treated were compliant if they were on 4 topical medications. So that must make you think a bit, isn't it? So the problem is that prostaglandins don't lower the pressure as much as you want. So you need to put a next one in. And nearly 1/4 require an additional drug within a year of starting treatment. But you have to give them 6 weeks' time, one, and you have to expect 30% reduction. If it's not, you switch in the class. Don't add. If it's not a minimum of 25 to 30% reduction, switch the PGA to another class in the same PGA. Don't keep adding because your first drug is not working in the first place, right? So when it's not enough, you add a second agent. Now the question is, when you add it, should it be a fixed combination? I hope you understand what that is. 1 bottle containing 2 medications, that's a fixed combination, or are you want to giving him 2 drops? Intuitively, which is better? Which would be better? Fixed combination, isn't it? The problem is that the fixed combination may or may not work as well as 2 separate, which is true. The factors to keep in mind are efficacy. You have to be sure that what you're adding is also working. So in practice, when you start with 1 bottle, you add the next bottle only if you see an additional 15 to 20% reduction. Then you know your second is working as well, and then fuse the 2. Because if you're going to fuse the 2 right in the beginning, you have no idea if the addition has worked or not. So the choices are, of course, beta blockers, which is the most important. Timolol is added to everything on earth, on prostaglandins, it's added to carbonic anhydrase inhibitors, it's added to brimonidine as well. Otherwise, alpha-2 agonists with carbonic anhydrase inhibitors. If you're taking pictures of this, go back and read what these classes of drugs are. That is important, right? Because that's a very didactic. So these are the combinations, just to tell you. Dorzolamide or brimonidine with timolol, dorzolamide with brinzolamide. So you have these combinations which are coming in. Advantage, of course, you know, 1 bottle versus 2, compliance, and etc. So non-compliance is the most important problem that we have. I always ask my patient, कब से दवाई नहीं डली है? If the IOP is not as I expect, and invariably they will say, हाँ, हफ्ता भर से नहीं डाली है. The silliest answer, which I have never been able to understand, क्यों नहीं डाली है 1 हफ्ते से? क्योंकि यहाँ की appointment थी. हाँ तो? अरे यहाँ की appointment थी, तो I want to see whether this drug is working. Oh. So next time, so it's another visit. It's silly. I don't know why they do that, but I've talked to my colleagues in medicine and endocrinology. They say it's exactly the same. They will stop their diabetic medication 1 week prior to coming. Arey, why? I want to see your sugars with medication, but remember, this is what happens. Side effects, remember, you have side effects of preservatives, which is, tell me, which is the worst preservative in any drug? BAC. What does BAC stand for? Benzalkonium chloride, isn't it? So this is BAC toxicity. That is one. But remember, not just BAC, but also anti-glaucoma drugs. What do you think this is? First one? These big lashes, Sundar? Huh? Alpha agonist, nahi, bimatoprost. Whenever you see horrible lashes like this, it is bimatoprost. Kajal milta hai aajkal bimatoprost ka, right? So there are women who, actually, I'm not joking, you have kajal, you have this eyebrows, women who have very scant eyebrows, they use, it's available. This you must know, this is prostaglandin associated periorbitopathy, PAPS. This is what you guys will see, because our generation has flooded 10 years or 15 years of glaucoma patients with prostaglandins. So you are going to deal with PAPS. So this is a typical sunken periorbital fat atrophy, discoloration around. So this is really bad, and this is something that we have done iatrogenically because we believe prostaglandins were the manna from heaven. What do you think is our answer to that now? Don't give drugs, do MIGS, right? That is the answer to that. So let's not forget, if PGA is not first line, they can't afford whatever, usually it's timolol, but remember, from 30%, this is a 20% reduction. So that's a problem. If it's not enough, it may make sense to substitute a PGA with another PGA before adding timolol. And if a PGA is not advisable, like in acute uveitis or early postoperative or trauma, why? Why would I not like to give a prostaglandin in these acute conditions? Because of cystoid macular edema, right? So the adjuvant can achieve about 30% reduction if you combine the two. So it's a good idea to give brinzolamide and a carbonic anhydrous and brimonidine together. So combine both of them and avoid a PGA in the first 6. So in a nutshell, I'll just run through this. Medications and laser and surgery are all effective in lowering IOP. There's no doubt about that. PGA analogs are constantly superior to the other drugs. IOP lowering ability as well as the adverse effect profile. But now we are getting PAPs, which we didn't see before, but we are getting it now. Patients treated medically or surgically, if you reduce the pressure, they are less likely to experience progression of visual field and optic disc damage versus those who receive no treatment. So no matter what you do, you have to reduce the pressure if you have a patient with glaucoma. Right, and I told Dr. Suresh I have to give them an overview of the babies. Don't go back thinking that childhood glaucoma is rare. Childhood glaucoma is, I would say that in terms of person blind years, which means the number of years a person is going to be blind, it is second to cataract, and this is the WHO finding. So if you have a baby who is blind at 1 year, it has to have 70 years or 75 years of blindness, which is the same as an 80-year-old who is blind of cataract, and you don't operate him till 81. That's 1 year of blindness, remember that. So in terms of blind years, if a baby goes blind, and Simar is sitting here, he understands because he does ROP, if a baby goes blind, you have lost an entire lifetime to blindness. So therefore, I want to give you just a quick overview of the babies. It's a potentially blinding condition. The problem with this particular glaucoma is that it doesn't stop at IOP control. For everybody else, I said IOP, IOP, IOP. For a baby, it's IOP, it's cornea, it's amblyopia, it's strabismus, it's refraction, it's retina. There are a whole lot of gamut, the entire ophthalmology. I can tell you, if you start doing pediatric ophthalmology or pediatric anything, you will be a much better ophthalmology clinician than if you have an adult. And I can tell you that because you will have so much to do. So this baby, for instance, this is a small story, comes like this, scars after IOP treatment, has one PK, has PK in the other eye. Now it's a lifetime of dealing with saving this graft, spectacles, amblyopia, strabismus, and everything. But they do come like this as well. So you've lost the battle if you have children who come to you like this. Sadly, and I'm without any caveat, I'm saying it, these are children who have gone to ophthalmologists, who have been told, abhi bachcha chota hai, isko thoda 4-5 saal ka ho jane do, phir operation ho jayega. There is no such thing as bachcha chota hai. There is no bachcha with an ophthalmic problem who is chota. When a bachcha has an ophthalmic problem, the emergency is much more than when you have an adult. So, preterm, no. It's okay, preterm. Bhej do kahin yaar. Koi na koi to hoga. If there is a problem, if the child is preterm, the child is a neonate, nothing. So these are the challenges. Of course there are challenges. Nobody is saying it's easy, but you have to have a heart to take care of them. They're difficult to examine. You have no idea what they have. It's a surgical disease, and it's difficult in small eyes. Post-op follow-up needs repeated GA. One glaucoma where goal is not target IOP, and you have complex problems because it's not an eye, it's a family. इसका एक और छोटा बच्चा है जी, मैं नहीं आ पाया जी, मेरे ससुर को कुछ हो गया जी. All these things will happen. The entire family has to chip in to bring a small baby to you. It's easy for you to say 6 weeks follow-up. It's not easy for them to come. But is it difficult to examine? These are snapshots from our clinic. So they will let you take pressures. These are 2-year-olds, 3-year-olds. We are doing gonioscopy. This is an old photograph. I have black hair at that time, but I love this picture. By 6 years, they are on the visual fields. They let us look into their discs. They let us do a gonioscopy. They let us take their pressures. Now we have the eye care even smaller. Before it was about 2 to 3 years by the time we could do Goldman. Now I can do eye care in a 1-month-old baby as well. So in that sense, we are better. This is my slit lamp. So a lot of my residents start doing this now. It's an SLR camera. You take one snapshot, zoom it out, and that is a slit lamp for a baby because he's never going to sit on it and let you see. At least you can see what it has. Why is knowing what they have important? I'll quickly go through this. most present with a cloudy cornea. In the older literature, about, say, 7 or 8 years ago, primary congenital glaucoma, and you went to the papers for the definition, was ophthalmos, cloudy cornea, raised pressures. If you phenotype them, if you see them, each one of them is a different disease. And each of these different diseases in children have different prognosis, different managements, different things to deal with. So if you have acute hydrops, the mother will come distraught. Kal tak theek tha, aaj subah dekho ye safed ho gaya. You will be the hero forever. You do a combined trap with trap. Now we started doing GAT in them. They will be absolutely normal children. They are just PCG with acute hydrops. This is neonatal onset CU, the worst disease and the worst glaucoma possible. No matter what you do, the glaucoma is refractory, there's CYP1B cytopathy, the cornea scars, it's very, very difficult to take care of these children. Congenital primary aphakia, I have done this for lack of knowledge. So I'm just bringing these pictorial things. If you see a silvery bluish cornea like this in the middle, recognize congenital primary aphakia, because if there is no lens, the rest of the anterior segment does not develop, the ciliary body is hypoplastic, you enter that eye, you will have phthisis in a week. And it is only when this happened that I now know. And now we shine a torchlight and I said, isko haath nahi lagana, CPA hai. Right? So what do the children need? They need +10 glasses, and they are visually good with +10 glasses. They're ambulatory. So you don't need to do anything, maybe give some drops if the pressure is high, but just a +10 glass. This is CPA. What do you think this is? Small eye, white cornea, cupping on ultrasound, and if you have a UBM, a cataract. Tell me what this could be. Rubella, you have a glaucoma and a small eye, and you have this monkey facey sort of thing, this tiny little monkey little baby, which I call it. It's bilkul bandar jaisa baby hai, so this is rubella. Test the child, test the mother. Why is it important? Look for heart defects, look for hearing defects. There are children who I didn't know better. This has been a journey. When I realized this was rubella, there were some children who were global developmental delay going to prayas because I was stupid enough not to get a hearing test done, and all they need was a hearing aid. He's not developmentally delayed. The poor kid can't hear. Right? There's sensory neural deafness in congenital rubella. So I'm just bringing these little things. So this is, of course, this is what CPA looks like on the UBM. No lens, disorganized zonules. And these are what these children look like. So we have lots and lots of them coming in now. We've learned not to touch them. Silvery cornea has a ajeeb sa shine. This is congenital primary aphakia, right? Okay, surgery is difficult. We'll just, I think, skip the surgery. Goniotomy is our savior now, goniotomy and GAT. And if you treat it in time, all these babies will go to school and they'll be normal children. Now, this baby is 1 day old. If somebody had said, ye bahut chota hai, mat karao, this baby wouldn't have become this normal kid. So remember that, take this message home. And of course, post-op needs repeated GA. I'll just skip this, axial length. All right, okay, this is interesting. So unilateral ophthalmos, high myopia, cornea cleared, but the baby is -20 in one eye and about -1 in the other. You think this child is ever going to see. And remember, you're in the business of vision. If you're in the business of vision, there's no point saying pressure 10 hai, retina on hai, whatever hai. हाँ, पर बच्चे को दिखता तो है नहीं, can't see. हाँ, दिखता नहीं है because he has -20 glasses, so do something. So what we did was we did a refractive exchange. He has an IOL in the right eye, not for a cataract, but for the anisometropia. And now this baby is all right. Now you've given him binocular vision and gone up. So that's interesting. There are complex problems. Sturge, Weber, I'll stop. All right, babies have a life. So what do you think this is? Though there is a caption, what do you think this is? This is the entire lens which is into the defect of a Peters anomaly, right? This is the lens behind the cornea. You think this eye is ever going to see anything? This eye is never going to see. You bring the pressure down, it scars, there's no vision, it's an unsightly blind eye. So remember, you have an opportunity to make a difference in the child's eye. Get your oculoplasty colleagues on board. Tell them to give prosthesis. At least this child can go to school without people pointing a finger and saying, "Ye dekho iski aankh kaise ajeeb hai." Nobody knows iski aankh hai hi nahi, right? So they do have a life, they grow, They're fine, they go to school, but it's a responsibility for you. I'll skip this also, someday we would. So clinical examination is the hallmark, and these are families that we have, 3 generations of Axenfeld. Grandfather blind, father low vision, child 6'6", going to school. Each one of them not caught in time. The last one was caught in time because the grandfather and the father brought the baby in when she was 1 year old. So caught in time. Microcerophakia again runs in families. We have lots of siblings with microcerophakia, and I can't thank my residents enough who work day and night, believe me, for me to get this in place. Thank you.